And I want to ask you, what is the difference between the European guidelines and our guidelines? Anyone of us get involved. यूरोपियन और हमारी गाइडलाइंस में क्या फर्क है? डू वी हैव ए गाइडलाइंस इन आवर कंट्री? आई वांट टू आस्क यू, डू वी हैव एनी गाइडलाइंस इन आवर कंट्री और नॉट? आई वांट टू आस्क यू.
Foxy guidelines.
Yes,
Very
sir,
good.
there is a guideline.
Very good.
Number of
Very good.
pregnancy
Because you
loss.
look at the guidelines for the Foxy, which was brought out by Dr. Jaideep Tank. What is the age of the fetus? Who will answer? Age of the fetus is how much? So it is 20. Fine.
20.
It is 20. And in case you go to the other guidelines, which we have, the European guidelines, they
20.
go to, in case you look at these guidelines, they go to
So your
the,
screen is not visible.
yeah, I cut my screen. I wanted to say hello to you. I cut my screen. Can you see my screen now? Can
No,
you see?
sir. 24 weeks, sir.
24.
Can you see it now?
Yes, sir.
Yes, sir.
Okay. So 24 weeks. Can you see 24 here?
Yes, sir.
Great. So when you look at Indian guidelines, they may talk about 20 weeks because the RPL, they say, could be considered after loss of 2 or more pregnancies, 24 weeks of gestation. So why is it 24 there and 20 here? Or why the age gap we consider?
They have better neonatal resuscitation, sir.
Excellent. Who said that? Who said that?
Ilamati.
Ilamati, super hai. So then we should look at both ART and spontaneous. Ectopic and molar should not be included. This we all agree. So we look at, they say we look at biochemical. Either we have a positive urine report or a serum report, including non-visualized pregnancy losses. Or so they say that we should be having a heartbeat on, or we can take the biochemical pregnancy losses also. What is the prevalence of RPL now? Who will tell me? What is the prevalence of
1
RPL?
to 2%, sir.
1 to 2%.
So
Okay.
Yes, sir.
Fantastic. Fantastic. Look at this now, guys. Look at this.
4%.
So look at this. This is a very nice thing that you see here. So we are looking at the pregnant woman. The risk is, if you look at how much is the risk we have, about it's around 1 to 2%, maybe 4 to 5%. This is what they normally talk about. And they say that all clinically recognized pregnancies, they have 10 to 15% risk. 15% risk. Sporadic is 10 to 15%. After one loss, it becomes 15 to 25%. Two losses, 25 to 40%. That's okay. It keeps going up. And normally it affects 1 to 2% of couples globally. The global prevalence is they have given over here. And 5% of more than 2 losses, 5% of fertile couples globally can have RPL. So 1 to 2% to 5%, depending upon 3 or 2 losses, is what they are talking about. And they say that RPL 3 plus losses, 1 in 300 pregnancies. And every pregnancy, it will increase the risk. Is this much clear to all of you? And every worldwide they have given over here, India, it will be around 4 to 5%. Is it clear to all of you that after one loss, it become more? 10% it's increasing with every loss. Is it clear to all of you?
Yes, sir.
Yes, sir.
Fantastic. Now, what is primary and secondary recurrent pregnancy loss? Who will tell me this?
So primary loss if there is no pregnancy which has gone till 20 weeks, and secondary if one pregnancy has gone till 20 weeks
Very
or
good.
24.
And then they have above. So this is what I want to show you. What is primary RPL? What is secondary RPL? So primary means that three or more consecutive pregnancies before with no prior successful live birth. Then they say that 2 or more pregnancies, do not specify consecutiveness. And then we have got RCOG, which says that 3 or more pregnancies, and they must be consecutive. These are different, have bodies have got different definitions. Now coming to couple, no prior live birth, multiple pregnancy losses, primary RPL, and we've got one prior live birth, and then they have got a loss. then it is called secondary RPL. Some overlap is always there, but secondary means that they have got one normal pregnancy and then they are having losses. Is this much clear to all of you?
Yes, sir.
Done. Okay, guys, so let's now move on. We are at 300 count. What are these? So this is a part 2. This is part C, risk factors and health behavior. So what are the known risk factors of recurrent pregnancy loss? Who will tell me? I want to ask you people, what are the known risk factors of recurrent pregnancy loss? Will someone tell me?
Factors, sir.
Diabetes.
Anatomical,
Anatomical
endocrine,
abnormalities of the uterus.
Congenital and
And
endocrinological.
thrombophilias are there, anatomical defects are there,
Very good.
and
Super.
endocrine
Immunological
problems
causes.
like
Obesity.
PCOD and hyperthyroidism or
Obesity,
hypothyroidism.
luteal phase
Obesity.
deficiency, hyperprolactinemia,
Yes,
genetic
all have
causes,
read. All have read very
genetic
hard.
causes.
Super.
Diabetes,
So here,
uncontrolled diabetes.
good day. Let's see one by one. The risk of pregnancy loss is
Immunological
low.
causes.
Yeah, very good.
Antiphospholipid antibody.
Super. Super. You've all read. So age
Good evening,
more
sir.
than
Thirty.
yes, yes,
Raksha.
yes, Rakshan.
Good evening, sir.
Good evening. How are you? How are you?
Good, sir. Nice to see you.
Same with me. See, very happy to see you smiling, guys. And it's a difficult topic, but be with me, keep asking questions, and that's the way we will take it ahead. Good. Ilamati, Rama, Menka is very serious. Tulsi Devi. Menka is always very serious whenever I look at her. Okay, I hope my screen is seen. I think it got unshared. Now my screen will be visible to all of you. So now, so one is the age. Age less than 35, age more than 40 is a problem. It's a strong evidence you can see here. And the level of evidence is low. Then stress. Can stress lead to RPL? Can stress lead to RPL? Any one of you?
Yes, sir.
Good.
Yes, sir.
So the stress is strong. See, there is no, it can, but couples should, that no evidence of stress is the direct cause of pregnancy loss. So this is a strong evidence, but it is a low evidence. So I think it is, I say that it is stress can lead to. This is what I understand. The evidence is lacking. Are health behavior modifications relevant for reducing risk of pregnancy loss? Health behavior modifications. So health behavior means, say, smoking. Can smoking lead to RPL? What do you say about this, guys? What do you say about this?
Yes.
Yes, sir.
yes, yes, sir.
Can lead.
Yes.
Yes, sir.
Okay, when GPP says it's a good practice point, it is not recommendation. It's a GPP, but it's a negative. We should leave smoking and obesity. How about obesity?
Yes.
Yes, sir.
Yes, sir.
RPL. Okay.
Yes, sir.
Negative impact, but the guidelines are so. This is a strong recommendation.
Yes,
Level of
sir.
evidence is low.
High
So
altitude, sir.
high altitude. Okay. High altitude is
Alcohol,
something.
caffeine, alcohol,
Caffeine.
alcohol intake.
Yes. Super. So GPP, we have to lose our weight. So smoking, alcohol can lead to problems. Aage alcohol aa gaya. You said alcohol is there, and we have to limit alcohol consumption. Good, absolutely good. Part D is an investigation in RPL.
So is
Medical
it
and
environmental cause, environmental factor?
see, I'm not going to anything, ma'am, which is not covered in ASHRAE guidelines. But
Okay.
environment
Okay, sir.
does cause. If somebody
Okay.
is staying in Delhi, when we have got AQI index of 800, definitely it is preterm labor and abortions are known.
Okay,
But
sir.
topic is recurrent abortions. So recurrent
Yes.
abortions probably in some time, the way the world is burning, it will come up. But till now, they've not spoken
Yes.
about pollution in any of the guidelines. Neither ASRM, not ASHRAE, not
Okay.
RCOG, not FOXY. Even our
Okay, sir.
guidelines are basically speaking only on progesterones. Have you seen the guidelines of Oxy? उसे पढ़िएगा मैं भेजूंगा आपको रात को
Yes.
they talk about more
Yes,
about
sir. Yes.
progesterones So
Okay, sir.
we have to review their history, lifestyle of both female and male partner. So family history of hereditary. So what is hereditary thrombophilias? Yes.
Like inherited, sir, like protein C, proteinase deficiencies.
Protein as antithrombin, sir.
Yes, protein C, protein
Protein,
S.
proteinase, prothrombin deficiency,
Factor V Leiden
and
deficiency.
factor V Leiden.
Wow, 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 wow.
Prothrombin gene
Super.
mutations and activin
Antitroglycerase
Leiden
deficiency,
mutations.
factor V Leiden.
Yes, this is hereditary. ठीक है. By the way, I want to ask you one thing. Would you like to check? Would you like to check? Would you like to check hereditary thrombophilias in the people who have got RPN?
No, sir. Not
No, sir,
required.
unless there is some proven risk factors.
Not
The
required.
history is there.
That's a
Not
crazy.
compulsory.
How much you have read? How much you have read?
Any
How
history
much?
of
How,
losses
So
is there.
if history suggests so, then
History suggestive of trauma.
thrombosis in the younger age
super.
group.
Salute to all
Family.
of you. Salute to all of you. Now, this is my third curtain raiser on RPN. I've also matured. मैं भी बड़ा हो रहा हूँ. Hi Pranali, how are you? I'm also maturing with time. But the amount of knowledge you people have is too much. But I'll know more than you. I'm going to confuse you in some time. Will discuss about today. I'm going to focus on immunity, immunological factors. But that I will know more than you probably. But I'm so happy to see you guys. So happy that you know so much. And now we are at number 300. So good way to move on. Everyone is discussing just from Monica Devang. So guys, let's talk less. And Monica is saying that we are disturbing. Okay. So medical and family history, good practice points. And important is base prognosis in women's age and their complete pregnancy history, including pregnancy losses, live birth, and their consequences. So we should take complete history, and this is a very, very strong recommendation. Level of evidence is plus, plus, plus. This is a very important thing, and we should take complete history of the patient. We all do. Look at this. This now. Can you see my screen, guys? Can you see my screen?
Yes, sir.
Yes, sir. Yes,
Smoke,
sir.
smoking, strong. Evidence, low quality. Alcohol, GPP, evidence, low quality. Weight management, strong. Evidence, moderate quantity. And psychological, strong. Evidence, low quality. This is what I'm telling you that recommendations are different from the evidence. Evidence quality is low, low, low. Not very low, but low or moderate. But recommendations are pretty strong ones. So I think, guys, we shouldn't smoke, drink, weight management, and stress reduction. In medical history, very important is most important, which I see is that we look at this age. ये strong and high quality है. Strong and high quality. यहाँ पे सब कुछ ही good है. So detailed medical history, paternal conditions, autoimmune disorders, moderate quality. So these are all medical history, age, family history, and pregnancy loss and history is very, very important. So I hope all of you are doing and doing it properly.
Yes.
Okay, good. Very nice. What is the value of screening for genetic factors? Genetic factors. Should we do or not? Who will answer this question?
If first trimester losses is less than 8 weeks, you will indicate in further genetic evaluation.
Sorry, can you come again, ma'am?
Yeah, multiple pregnancy losses in the first trimester losses is there, you have to go for the genetic evaluation.
Okay. Okay. Anyone else, right?
Below
Sir,
6 weeks.
genetic factors are like to be checked when once there are two or more losses, but